Apologize.
Okay. Good evening, everybody. Welcome to the first webinar series for the year 2022, and we are kickstarting it with Dr. Mahmood Bhutta, who will be talking to us today about the supply chains for medical products harming our planet and financing labor abuse. And the moderator for this evening is Professor Chirantan Chatterjee, who is our very own co-principal investigator at IHOPE. So I'll hand this over to Professor and ask him to take this forward. Prof, over to you.
Thank you, Arnaz. Thanks, Dr. Bhutta, for giving us some time on your very provocative stream of work. Just a quick heads up, and then the floor is back to Dr. Bhutta. I basically got introduced to Mood, as they call him here fondly, through the Dean of the Sussex, the Brighton and Sussex Medical School, Professor Malcolm Reed. And I learned very curiously that Mood is asking some questions that all of us in working in health systems, both in LMIC and non-LMIC context, should be asking, given the dramatic rise in medical consumable consumptions that are happening around the world with the pandemic. We had a very nice chat over lunch on how the global supply chain issues are related here. I, of course, came here with an economist's trade-off kind of a lens. And Mood was trying to point to me how there are issues here on creating a green NHS while not being inattentive to global supply chain and financing and green issues and human rights abuse issues. So with that in perspective, and Dr. Raja was saying that LV Prasad Eye Institute and IHOPE is also very mindful of these issues in Indian context. I thought that this kind of a webinar would be very timely. So thank you, Dr. Bhutta and Professor Bhutta, for kicking off the webinar today. Over to you to take it up. The format that I'm thinking of is he would go forward with a 30-minute presentation. And then if you have questions, you can put it on the chat window. We'll open it up after 30 minutes for a Q&A, and I will moderate the chat window interventions. If in the middle of this you have any clarificatory questions to take, please use the raised hands thing, and I will moderate the interaction between Professor Bhutta and your question. Over to you, Professor Bhutta. Thank you.
Thanks so much, Chirantan. So yeah, hi, I'm Mahmood, as you've already heard. I'm a jobbing surgeon. I work in ENT in Sussex in the south of the UK, but also work at the medical school. And I've had a long-standing interest really in supply chains for medical products. Really, my interest started in uncovering unsavory working conditions in the production of medical goods, and I've now also started really working in earnest on the environmental harms as well, which I was always interested in. So just to give you some background, I mean, I could talk about this for hours, so I'll try and keep it to half an hour. But I started this work really in 2006, where I wrote an article in the British Medical Journal, looking and questioning our supply chains for surgical instruments, and I'll come on to talk about that a bit later. But also in 2008, I was there when something called the Centre for Sustainable Healthcare was being set up, and we suggested that healthcare was not good for the planet and that we should try and do something about it. I'm glad to say that this is now becoming a mainstream idea, and I'm certainly very busy with requests all the time on this topic. So just to give you some background to the problem in terms of the green agenda, some of you may be aware, some of you may not, that healthcare is responsible for a large component of the carbon footprint of nations. So this has been most clearly documented within England, where there's been a detailed analysis of the carbon footprint, if you like, carbon obviously being the most common metric we use to measure environmental harm, that greenhouse gas, although there are all sorts of other environmental harms. And that's 25 million tons of carbon from the NHS in England, which is actually 4.6% of national greenhouse gas emissions, equivalent to the entire emissions of a country such as Croatia. So the NHS, the National Health Service in England, is responsible for huge amounts, and there's been parallel studies showing it's similar probably across the world, although I think the US takes the biscuit for being much, much worse because of their incredible use of resource. So all four nations in the UK have aimed for a net zero health system by 2045, and that includes everything in healthcare. But actually at the COP26 conference, 50 countries signed a pledge to develop low carbon health systems. So what does that include? So I'll just mention some of the principles. Reducing care is obviously the best thing that we can do where appropriate. Reuse, particularly of equipment, for example, is important, and recycling is a minor component of all of this. Everybody seems to get obsessed with recycling, but it's certainly not the answer. So what we have in the NHS is a breakdown of the emissions of various products, or various activities, I should say, in the health system. And there is work going on. I also am the lead at our trust for our green strategy. And there's work going on all of these components, if you like, this wheel of what creates the carbon emissions within healthcare based upon modeling data. And so what we find is things like, there's easy wins like green electricity, using insulation for our buildings, using LED lighting to reduce building and energy use. There's things like waste segregation and recycling, which, as I say, is a small component of all of this. There's things like eliminating toxic greenhouse gases that are used in anesthesia, particularly desflurane and nitrous oxide are two very potent greenhouse gases. So nitrous oxide, for example, is 300 times greater greenhouse gas potential than carbon dioxide, and desflurane is thousands of times more than carbon dioxide. So we've really got to eliminate the use of those. And then it's about transport, remote consultation, remote working, and green transport. But actually, the supply chain to the health system is responsible for around 2/3 of everything that is the carbon footprint of healthcare. And we really need to look at that. And that is a difficult thing because it's outside of the direct control of health systems, but an important thing to look at. So that includes medicines and chemicals, and also non-medical equipment and things like food. But I'm going to concentrate really on medical equipment here. So I'm going to use the example of the operating theatre, because the operating theatre is the worst place for the use of equipment. We are incredibly intensive in the UK, and I think some of you are coming from India would be shocked by what we use in the operating theatre. So it's the most resource-intensive area of hospitals, generating up to 1/3 of the total waste of a hospital, and 3 to 6 times higher energy consumption than other parts of our hospital system. And a typical operation is known to have a carbon footprint, that measure of greenhouse gas emissions, equivalent of driving from London to Edinburgh in a petrol car. And the hotspots from a systematic review are things like energy use, which we need to move to low carbon energy and more energy efficient systems, anesthetic gases, but actually our anesthetic colleagues are reducing these most toxic gases, and that has come down a huge amount. But the other thing is consumable equipment. So I'm supervising a PhD looking at carbon footprinting, and these are some results that have not yet been published, looking at the carbon contributors of 4 of the 5 most common operations. The 5th operation is still being analysed. What contributes the greatest amount of carbon of the actual operation? Now, I appreciate that surgical care is not just about the operation, it's disease prevention in the first place, of course, and appropriate care. But nevertheless, this red bar shows you that single-use equipment, its and its waste is the biggest contributor to the carbon footprint of all of these operations. So actually, single-use equipment that is the major area we need to tackle, and recycling, as I say, is not the answer. So here's an analysis as well. It's not just, it's not necessarily the type of approach you use. This was an analysis done in the USA of different approaches to an operation, the hysterectomy, removing obviously the womb. And you can do this through a vaginal approach, an abdominal approach, a laparoscopic approach, using gas and instruments, keyhole surgery, if you like. You can also do it using a robot. And what we found is actually most of the contributors to the carbon footprint of that procedure were similar, except for the use of single-use equipment. And I can't see any reason really why you have to use so much single-use equipment if you're doing a laparoscopic approach or you're doing a robotic approach, as opposed to other approaches. And this is really where, in the operating theatre itself, we need to target these things. And we can also compare different models. And so, I'm very happy to compare to the Aravind Eye Hospital, where they do cataract operations en masse with a high throughput, highly efficient system, where all equipment, wherever possible, is reused, compared to a carbon footprint of a cataract operation in the UK, where we find a 30-fold difference in the carbon footprint of the actual procedure. So I think we've got a lot to learn from countries such as India, in that you can do this in this way. And the only idea that it is associated with increased risk of infection is also not borne out by the evidence, because actually from the eye center, they reported lower rates of infective endophthalmitis from an analysis, I think, of 2 million operations. So this is, I think, the standard we should be going for. So to deconstruct all of this, I think I do like to look at the market dynamics of medical supplies, and hopefully Chirantan will be pleased to see that there is some sort of, I'm not an economist, but I'm trying to dabble in this area. I'm trying to get Chirantan to come help me with all of this. But the market dynamics of medical goods are somewhat different to the dynamics of other goods that we may purchase for personal use. So we have a consumer, which is the actual patient. We have a user who is helping the consumer, and we have a purchaser and the payer. And those are disconnected. And that's different to other market dynamics, where usually the person who's buying it is also the user and the consumer. So, obviously I buy a telephone. I want it to work. I want it to last. I don't want to have to keep buying it. But here we have a different dynamic, and suppliers are well aware of that dynamic. And look, I'm going to paint perhaps a slightly negative view of the commercial interests of these suppliers, but I'm afraid the reality, my experience is borne out by that reality. So suppliers may try to look at this interplay between user and consumer, and here they will try to, in the UK and in other high healthcare settings, sell us high-cost products where we say these are the greatest standards of care to provide for your patient. And of course, doctors want the highest standards of care, and those are the high-cost products, whereas they can also interplay in this relationship between the payer and the user, where you're buying products en masse. They want the low-cost products, but at high volume. So things such as gloves and cannulas and the sorts of stuff that we just use all the time. So what that engenders is this dynamics, I think, of medical products, where with high-cost products, there's a high embedded carbon. So there's an incredible amount of carbon embedded within the production of a highly complex piece of equipment, from the raw material extraction to the production to the transportation. And unfortunately, a lot of it is designated as restricted or limited number of uses. The amount of equipment that we have a harmonic scalpel, for example, this highly complex piece of equipment to sort of using thermal energy cut through tissues. Fantastic piece of equipment, and it's single use. It has to be thrown away. And I'm slightly pessimistic about why that is. Is it because of an infection risk? I'm interested in exploring, can we sterilize this, and why not? Is it designed to fail? And I can tell you, speaking to people who actually do look at this equipment and reprocess it, say a lot of this equipment is designed to fail. It's designed to become obsolete. It's designed to promote the linear economy of perpetual use of equipment. So we have a high number of uses, but the other opportunity is a high number of users. So for example, a robot, of course, you're not going to use a robot once and throw it away, but suddenly with that robot, you have to use a whole number of additional disposable components to perpetuate that continual sales, which I'm afraid is the backbone of the capitalist economic model. So the idea is, in fact, the whole ecosystem should be reusable where possible, and we should have cross-platform compatibility. So if you use one endoscope versus another endoscope, you can just use whichever platform you want. They would speak to each other. That's kind of part of the principles of a circular economy for medical goods. And then we see with low-cost products, of course, we want as cheap as possible. And what that means is we embed this in the free market economics model, where actually, we're just trying to get these products, and actually a lot of money is spent on advertising and branding to get these products to us. So I've been to Mexico, for example, and in Mexico, I went to a factory that's producing these knee bandages, and it was interesting to see them coming off the production line, and they went into 6 different boxes, exactly the same product, branded under different brand names, including a high-end brand that's supplying Western health systems and a brand that's supplying only in Mexico, exactly the same product. And we've seen this also with other goods, such as gloves. So Ansell, one of the largest manufacturers of gloves in the world, is based, headquartered in Australia, but it does its production in Malaysia. Malaysia is the largest producer of gloves in the world, and they have their own factories in Malaysia. But during the pandemic, what we found, actually, from research we did, was when they ran out of gloves, they just used many other glove factories in Malaysia to produce exactly the same product and rebrand it. So this is this free market economics. Wherever I can get these goods, I'll get them. And a lot of the money is on branding and selling to us. So the problem is that is about outsourcing production, is about disfragmented and global value chains for the production, and the responsibilities that may come with that seem to get dissipated within that. So we've had examples, and I could give you a whole talk about this, examples of products that are produced under unethical and poor labor rights conditions. So for example, during the pandemic, we found that there was reports in the media that some of the masks coming into the NHS and also going to American health systems were produced in the Xinjiang province of China, where using forced Uyghur labor. I'm sure many of you are aware of the cultural genocide of the Uyghur population in China. We were funding this. And beyond that, also within China, there was found to be North Korean forced labor being used in a place called Dandong on the border between North Korea and China, within China itself. This was state-sponsored, again, state-sponsored forced labor. These workers were reported to provide 70 to 100% of their salaries back to the North Korean state. And China was obviously complicit within this. In fact, there are studies reporting that 1 in 10 people in North Korea is working in state-sponsored forced labor. And again, this was coming into the National Health Service in the UK. And then gloves, I'm going to talk to you about gloves. 2/3 of the world's gloves are produced in Malaysia. And in Malaysia, we find that this outsourcing of production actually leads to forced labor using immigrant workers in the supply chain. And also, I've found problems with surgical instruments, where I started my interest in this. And surgical instruments are produced, for example, mostly in a town called Sialkot in the north of Pakistan, also some production in other countries such as China and India, and where there has been sweatshop labor and child labor. So this is the production of surgical instruments. I was in Pakistan. This is, I started this work 16 years ago. My origins are Pakistan. I was traveling through Sialkot where my parents are born. And so really my interest in this was by accident, by just being a product of this culture. And my cousin, I just asked me, do you want to see how these surgical instruments are made? And of course I did, because I was a trainee surgeon. And I was, surprised at the sort of labor conditions that were being perpetuated and not protected by those who were buying. All of these are rebranded and sold to German suppliers or UK suppliers and so on and so forth. And obviously you can see that these are sort of sweatshop labor conditions in the production. These people will typically work 13 hours a day. They're paid a piece rate, so they get paid for what they produce. They don't get any social security. They work for themselves. They work in these workshops. Injuries are common. Exposure to grinding wheels and dust and toxic noise, all of these sorts of problems. And it also includes the production of various other medical products, such as laryngoscope blades and diathermy forceps. So we've also found that there's child labor in the production of surgical instruments. And although there is work afoot in Pakistan to actually try and eliminate this, that is still widespread. And I've seen children as young as 7 producing these surgical instruments coming to the National Health Service. And I know that child labor is always an evocative problem. And it is really, I always say, it's a symptom of a failed system. It's not that child labor itself is the only issue we should be dealing with. If we had good jobs for the adults, of course, children would not have to work in this industry. And these children don't go to school, so it perpetuates this cycle of potential literacy and poverty. And we've done some work with these children. Of course, they want to go to school. Of course, they want to play with their friends. They hate this work. They want to play cricket in the streets. And then I'll take you to Malaysia. Now, Malaysia, as I said, produces 2/3 of the world's gloves, probably more than that now. And in the pandemic, of course, the production has ramped up. But I've known about this issue since 2016. And it all looks fine in the Malaysian glove factory, but actually all the workers who are packing it into these boxes, they're all immigrants. They've mostly come from Nepal and Bangladesh with the promise of this great work in this factory. But actually they enter into conditions of what can only be described as forced labor. They've paid huge recruitment fees to unscrupulous agents to come and work here. And we've done some work on this. And this is some of the accommodation that they might face. This is another company called Brightway, which is also supplying the NHS. The previous one was a company called Top Glove, the world's largest manufacturer. These are the accommodation in Brightway. These are shipping containers where these workers live. They have their passports confiscated. They cannot leave these containers. And this is not just some examples I'm showing you. Across the whole of Malaysia, in the production of gloves, there is forced, endemic forced labor of migrant workers. So we've done some analysis of interviews we managed to obtain of 1,500 workers in this industry in Malaysia. And we found that nearly half of them had taken out recruitment fees, averaging over $2,000, sometimes up to $5,000. These are illegal recruitment fees for the opportunity to go and work in a factory through recruitment agents in their countries, such as such as Nepal and Bangladesh. A third of them had reported that their recruitment agent had asked them not to say anything and threatened them if they talked about these illegal recruitment fees. And then most of them worked 12 hours a day. 1 in 10 had not had any days off in the last 3 months, and a third of them had just 1 day off in the last month. Half of them felt unable to leave their employment due to contractual or other restrictions. They normally take a year or so to pay off the debt. Once you're indebted, you work and you work and you work. And there are mental health issues. They are all, half of them report congested accommodation. I would say the accommodation pictures I've seen, they're all congested. They live on bunk beds, on concrete floors, forced, they can't leave their accommodation. They have their passports confiscated. So they are basically slave labor. So I've shown you 2 examples, Top Glove and Brightway, but actually, as I say, this is endemic. And this is all these companies centered in with Malaysian glove factories in Malaysia producing their gloves have had the same issues. In fact, Supermax just recently has had reports of beatings of workers with sticks and quite serious abuse in their factory. So we've actually tried to do some analysis. We have no real transparency of what goes on in these medical supply chains. It's very difficult, but actually I've been working with international partners and with the sort of procurement offices in Norway. We managed to get some data. They asked their suppliers to tell them where they would be producing their goods. And we mapped that to ITUC, that's the International Trade Union Congress, ranking of risk of labor rights abuses. Now, despite being contractually obliged to say where their products were being produced, half of these companies for 29,000 items did fail to report where their products were being made. But of the rest, 40% of them were being produced in countries with high risk of labor rights abuse. That doesn't mean that that definitely is labor rights abuse, but I have to say, so far, wherever I've looked with high throughput, low complexity products, we have found labor rights issues exist. So there are some of the ideas that perpetuate this linear economy that damages our planet in the way that we produce goods and also harms human rights because we want cheap, 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 cheap. And so I've been trying to break down what are some of the myths and the barriers that perpetuate this linear economy. There seems to be this myth perpetuated, particularly in high-income countries, that carbon and financial costs of single use may be better because these products are slightly different to other things, other products. If you want to reuse it, you have to sterilize it, you have to transport it to somewhere to sterilize it and bring it back. And there's a risk of infection control there as well. So somehow medical products are different. But the analysis that we've undertaken, this is my PhD student Chantel's data again, she's shown that single-use scissors, for example, have a carbon footprint that is more than 10-fold higher than reusable scissors. It just makes sense, and we've demonstrated that, as well as the cost is higher. That's the full life cycle cost. That is including sterilization and so on. And this is borne out by a systematic review that I was also involved in, where they've looked at disposable surgical anesthetic equipment and all the studies that have been done, but all of them pretty much favor reuse as better for the planet and financially better. So the only 2 exceptions were a study from Australia where they were using coal as their energy source for sterilization. I mean, frankly, we need to stop using coal. It is so dirty. And the other thing was from a study sponsored by a manufacturer where the data were incomplete. And so we really couldn't try and break that down. So other factors perpetuating the linear economy is the myth of sterility, that actually if you reuse something, it is no longer, it poses an infection risk, Well, I think the data from the Eye Hospital do dispel that idea. But in the UK, we used to have processes for inconsistent or inadequate sterilization. So data from the 1990s showed that people were using these tiny little autoclaves, steam sterilizers in the back rooms of their practice or dental surgery to sterilize equipment, and it wasn't up to standards. There was no verification. And what happened is we got this disorder called CJD, where there are prions, these misfolded proteins that can survive on surfaces and which cause a degenerative neurological disease called Creutzfeldt-Jakob disease. It sort of started in cows and abattoirs, and there were a few reports of this being transmitted to humans. And so this inconsistent and inadequate sterilization, together with this unknown risk, led to the whole single-use culture. But we don't live in that world anymore. So modern sterilization in the UK, I think it's fair to say, is to the highest standards possible. There's robust decontamination and sterilization to standards in order to for things such as laundry. This is laundry sterilization in one of the largest facilities in the UK that I've been to. And this is the sterilization also of equipment. And again, it's all audited, it's all checked. There is no way that your product is not sterilized according to national government standards. So we're living in the past with this idea of single-use equipment. And in fact, if you're buying goods from abroad, they are not subject to these standards. And there was an issue last year where there was actually found to be falsification of sterilization at a facility in Italy, where they just said they were sterilizing all these goods coming into the NHS as single-use equipment, and they were not. There were certainly some outbreaks of infection as a result of that. So actually, I say to all my colleagues, if you want sterile, you get it sterilized, and reuse is absolutely fine. It's sterilized and you can trace it. The other thing that it perpetuates this linear economy, I think I'm interested in the economic drivers. So there's this, as I've already mentioned, there's this disconnect, I think, between the purchaser and the user in healthcare, which is not found by other products. And that allows us to perpetuate this throwaway culture because I'm not paying for it, but the planet, of course, is paying for it. We also have models of procurement, I think, in health systems, certainly in the UK and in America and Canada, where a lot of the procurement is based upon product quantity. So if you sell us this, then we will pay you for the number that you sell, rather than alternatives such as servicing models, which may be appropriate for certain contexts. For example, if I want to buy colonoscopes to do and gastroscopes to look in the bowel, what I can do is I can provide you with a contract for 5 years for you to provide that service to me. Whatever goes wrong with those, you have to fix them, return them, and service them and provide them to me, but I'm not buying more of those products. And then I suppose what that creates is the idea that the supplier will have to invest in a circular economy because it's going to cost them if the product fails rather than cost the health system. And then the final point is we have these annual financial cycles for healthcare purchasing, which do not encourage long-term investment. They encourage financial cycles over a year. I've got to buy this rather than invest in something that may last longer. So a circular model, I just use an example of a gown. It's ridiculous that you can take a gown made of polypropylene, which is using fossil fuels as the raw materials. It will be typically made in China, maybe associated with labor rights abuses, using coal-based energy often for its production. We transported up to 8,000 kilometers. It's used once and then thrown away into clinical waste for high temperature incineration, which is a highly carbon intensive waste stream, versus a circular economy where you may have materials, where possible, made from recycled and reusable materials. It is reused typically at least 50 times through laundering processes. You actually have a higher quality product. It is repaired where possible and recycled materials at the end. Much, much better for the planet and for protecting this economy of throwaway culture that also perpetuates labor abuse because we're not prepared to pay for things. So looking forward, there are several aspects to this. I wanted to point out some successes. So we have been working on, and this is a separate talk about the work we've been doing on labor rights, but actually we've done some work with Pakistan, and there are some factories now that are actually looking after their workers, and they've found real benefits because all the best workers in the industry actually want to come and work at this factory. They said, well, here we're treated with respect, we're paid well. They get a high quality product, they get a happy workforce, it's a good working environment, but there's still major problems around the corner. And also, I've been working with colleagues looking at gloves, and actually I didn't go into it, but some of the companies have been banned from supplying gloves to the US because of these forced labor concerns. These are some of the companies that are facing bans, and they've paid over 150 million US dollars back to these workers in illegal recruitment fees, some of the biggest corporate payouts in history. And that's my colleagues that I work with that have enabled that. And there's a slow but sure cultural change in Malaysia saying that this cannot continue, but there's still work to do there. And looking forward, what I'm looking to do is I've been asked to chair a national report on what sustainability in surgery looks like. And I've got multiple surgical colleges, both from the UK as well as Ireland and America and Canada, to join. And so I hope we can speak with a clear voice that says this is the future of sustainability. But I'd also like to undertake an academic analysis of the circular economy, understanding all these complexities, bringing them together. And I've got people from Infection Prevention Society, from government, and from academic partners to try and take that forward. But it's a complex issue. And I think it's best if I stop there, and thank you for your time.
Thank you so much, Mahmood. I think people are indeed provoked by your your findings, your talk. Maybe we can take time for questions as people think. I do have 3 points to make, and maybe I can kickstart the conversation. And then Dr. Raja has an interesting point on single-use propaganda. So we can go to that. My quick question to you, Mahmood, is for health systems coming from LMIC contexts, how do you set up data systems that actually measure the carbon footprint? Like one of the initial pictures you showed, that this is how in different types of laparoscopy, this is the CO2 footprint. And you also acknowledge that CO2 footprint comes from production to consumption to final disposal. So if you could say a little bit about how to measure, set up measurement systems in hospitals for CO2 footprint, I think the audience will benefit on that. The second thing is on this ban that you ended the talk with. Banning is okay, but in some of my own research, I found that the ban is not effective on the ground many times. So is external regulation the way to go? And even within the external regulatory context, how do you harmonize all this? For example, we know that there are hospital systems in India who are reusing syringes, and that could have implications for reinfection risks. And we had this conversation on this bizarre story in the US of oximeter throwaways after single use, right? So how do you harmonize this internationally from the UK to India to US? And the last part is, what does it do to business models of different types of hospitals? Like LV Prasad is a not-for-profit hospital, but there are private hospitals, and then there are public hospitals in India. What can be done in terms of setting up standards and procedures to adopt? So if you could comment a little bit on measurement, harmonization of regulation, and this last point of, I forgot my question. This last point of how to, it will come back to me. Just if you can comment on the first
profit, the profit, the private, and so on. So yeah.
Different types of hospital systems. Yeah, the business models of hospital systems.
Yeah. Thank you for those very small questions. How do you change the entire economy of health systems? So let me start with the first point. How do you measure carbon? Well, I suppose there's two aspects to it. Is first of all, do you need to, and how do you? First of all, I do say to people, what we're trying to do through our research is actually show the principles. We need to dispel the myths that, single use is better. It's absolutely not better. So we don't need to keep proving that point. I think if someone wants to say, I've got a single use product and it's better than your reusable equivalent, it is up to them to prove it, rather than us try and carbon footprint everything. So the principles I'm trying to take forward, for example, within surgery are reuse is better than single use, of course. The remote consultation, we already know this. Remote consultation, where appropriate, is better than in-person consultation. Obviously, investment in public health and preventing disease in the first place is better. We don't need to prove that. General anesthetic is worse than local anesthetic. We don't need to prove that over and over again. So I don't want everybody to take away from this, oh my God, I don't know how I'm going to carbon footprint. What do I do? And how am I going to start? Because we don't need that. What we need is the principles that you can take forward, and that's a given. in terms of how do you actually carbon footprint anything? Well, if you want to do it to an academic standard, it's incredibly complex and difficult. And I wouldn't recommend that people try. What we are doing some work is with Chantal, who's my PhD student, is she's actually carbon footprinted all of these things, and her tables are phenomenal, how long they stretch out. But what we're trying to do is use that data set to see, is there an easy way to do that? Can you take, for example, the weight of a product and its composition and make a rough guess that's about right most of the time? So we are looking to develop that. It's a complex science, but we would like people to feel able to. If you want to learn the basics, there are some carbon footprinting courses, such as at the Centre for Sustainable Healthcare. I know they're inundated now with their courses. They're quite low cost courses. They're online. You can join from anywhere. If you want to learn the basics, that would be a good place to go. But like I say, I don't think that everybody needs to feel that we need to learn how to carbon footprint, because our planet will die whilst we're waiting for that. So I hope that answers your first question.
Harmonizing regulation.
Harmonizing regulation. So what I want to do with this report, for example, within surgery, and I hope it would serve as a model for potentially other areas of healthcare, is to bring everybody on board so that we all sing from the same thing. So by I'm trying to work with infection control people to say, actually, what's a sensible approach? So how can we have a traffic light system? So with syringes, it might be too high risk. I don't know. It probably depends on what you're using the syringe for. But certainly, I know in anesthetics, for example, they're mixing drugs given to the same patient using the same syringe, because they've shown that there's no cross-reactivity of drugs except for in a few circumstances. So they say, actually, don't put these two drugs in the same syringe. But actually, if you're giving, an opiate and an anti-nausea medication, you can use the same syringe. So there's data out there that says just use the same syringe. Between patients, I think it gets a bit more difficult. And so we may need to take a more balanced approach to that. And using IV cannulas, no, that's not a good idea. But for many, many other things, of course, it can be done. So what I want to do is work with the Infection Prevention Society, and the president of that, I spoke with her earlier this week, is very much on board to create this sort of almost traffic light system where you say, no, that's no good, that's okay. In certain circumstances, that's absolutely fine, But the idea that there's, people are worried about books, there's books in waiting rooms, they're covered in bacteria that live on your skin. Well, of course they are. So let's just take a sensible approach to that. I think there's an opportunity for people from LMICs in particular to feed back the data from what you do and say, actually, we don't find any problems. And I really want that, because I don't want LMICs, as some LMICs might see, that we are the standard. We are not the standard. We are destructive to our planet, and it's completely wrong. So harmonization is about getting bodies on board to say this is okay, to enable the leaders in the field to actually take that forward and feel emboldened to do so. So I think that's probably where we need to work, but it's a complex science of behavioral change, which is not easy to do and it will take years, but that's where we're working on. In terms of your last question about different health systems and different funding, I think that is a major barrier. So of course,
even within the same country. So we have a colleague from Marle Fernandez from LVPI who handles this at LV Prasad. She is asking the same question as well. So how do you synchronize this between different types of hospital systems?
Yeah, it's not so easy. But look, there is no doubt that the drive to make money is going to be one of the counters to what we need to achieve. Obviously, I'm talking about reduced care, but actually there can be in certain private hospitals, for example, the desire to increase care, to provide you with, facial plastic surgery, which is, I freely admit, is not something I do, but those may promote that idea as a medicalization of something that I think should not be medicalized, except in some very different circumstances. So there is some difficult questions we have to ask is, what is medical care? And is this morally justifiable? So, but equally, I think we have, I've seen some private hospitals where they think the standard of care is this. So we don't reuse any equipment because we have this fantastic standard of care. We always put gloves on whenever we touch a patient. Well, you don't need to, because you're not touching bodily fluids. So I think we need to get away from that mentality as well, where the standard of care is actually a standard of care that is low carbon. But we will always have that fight from commercial interest versus what is right for our planet. And I guess, again, it's about branding. I think the metric is changing. so that even patients recognize that good health systems are green and they would like that. What we found from the little bit of work we've done with patients is what they don't want to think is that the standard of their care is compromised as a result of what you're trying to do on the green strategy. And I've never suggested that that's what we're trying to do, but there can be some education. For example, in my hospital, we've had 2 complaints from patients who said, why were you not wearing gloves? Not me personally, but I don't wear gloves when I examine patients. If I'm examining your neck, I do not need to wear gloves. I will wash my hands, but there's that public perception that this standard of care is here, which then perpetuates the idea that if I'm providing healthcare of the highest standard to private providers, for example, I have to be at this standard. But that is not a standard, it's a falsehood. So again, it's complex, difficult behavioral change, but all of those aspects need to be brought in.
Okay, let's take some questions from the clinicians in our group. So Praveen, Shriram, Marlene, and Marley, and I think Christopher had some points from the anesthesia department as well. So if you want to unmute yourself and share your questions and keep it short if possible. Praveen, you want to go first?
Yeah, thanks, Professor Chatterjee. An amazing talk with some great insights, Dr. Bhutta. So just wanted to actually get an idea of the magnitude of the problem that seems to be ahead of us, because even if you look at the supply chain systems of hospitals, most of the decisions to buy bulk equipment or consumables is made by admins based on availability and cost, like you said. But then again, is there something that you foresee that you can get a regulatory body to maybe label these products about the carbon footprint or ease of reusability? I don't see that happening, at least here, because we still don't even have a body that regulates the quality of these products. So I guess it's going to be a long shot to try to get them to label them appropriately.
Yes, so it's a very good question. Again, I wish I had an easy answer. The problem with labeling is it just can encourage falsehoods. So, we found this, I didn't go into it because I didn't have time. So for example, with the gloves issue, I started working on that in 2016. And it was actually a contractual requirement that if you're going to supply gloves to the NHS, you had to demonstrate, for example, that you were not using forced labor. And all the gloves companies just said, yes, we're not using forced labor. And then in 2018, 2019, of course, they were all found to be using forced labor. So the problem with labeling systems is, they'd all been audited. The auditors had gone in and said, yes, everything's fine. Now, I don't know whether it was because those auditors were being paid by the company to say that everything was fine, or whether things were covered up and falsified. The problem is we perpetuate this idea, then we have to audit the auditors. And I'm scared that the same thing will happen with the green agenda. If we try to label everything, people will falsify their carbon footprints to say what they want to do, because if you have a bad carbon footprint, you're not going to report that. So I think that's one of the difficulties we have in this. But I think the idea of, we say, actually, what you can certify your product as being good for the planet is you certify it can be used this many times. I will guarantee this product will be used 1,000 times, or it's been shown to be okay to be used 1,000 times, then that's green and we don't need to worry so much. In fact, if you produce this horrendous, massive robot with a huge amount of embedded carbon, but I can use it 10,000 times, that's kind of okay, because the carbon, is split across so many different procedures. So I think that's what we need to get to. Your idea about the quality of products is a real problem. So the WHO produced a report on the quality of products, which obviously plagues particularly LMICs because there's no regulation. And they found very little evidence on this. So all we have is anecdotes, and I've seen it. I've seen the horrendous quality of some products being supplied. And, I was in Africa, and I know, shall we say, there were some Chinese products being purchased by the Ethiopians. They were purchasing surgical instruments, which in 6 months were covered in rust. And I said, well, why aren't you purchasing better quality products? And it's because of the procurement structures and shall we say, the agreements that we'd signed, I think, with the Chinese government to buy these goods. And that's just completely unsustainable, both from financial as well as environmental aspects. So I think it requires a lot of work to deconstruct these ideas and to have some quality standards brought into these sorts of countries. Who regulates that and how it's achieved, I'm not entirely sure. What I can say is in the UK, I have written to the Medical Health and Regulatory Agency, which regulates medical devices. They just had a consultation. I'm waiting to hear back what they will do, but I've asked them in the future regulation of medical devices to require companies to report why their product could not be made reusable, and for that statement to be made publicly available so that we can start to say, hang on, what is this about? Why are you making this single-use product? If you are prepared to stand by your product, then you should certify it and you should guarantee it. And we need that to spread throughout the planet.
Thank you.
Thanks, Mahmood. Sriram, do you want to unmute yourself and share what's happening at Oro Labs?
Yeah, thank you for this opportunity. Am I audible to all of you?
Yes.
Yeah. So in our lab, I would like to take this from two aspects. One on the products that we manufacture, and then for all these products, the packaging and the plastics involved, are significant. So we try to pack it in a manner, the minimum possible packing is what we try to do. The minimum use of plastics. LUP using is our blades. You may know we give a very, very small tip guard, using very less amount of plastics, compared to the other companies where they use a very large piece of plastic to protect the handle and the blade. So every single aspect of packaging, we really look carefully and then see how we can reduce it. Because when we reduce the pack size, the shipping box, whatever the flight that carries, all of that gets reduced. So this is one aspect how we focus on the product side. And in our factory, we do use electricity, and then we started using the solar panels in 2013, starting with 100 kilowatt. So today we have close to about 350 to 360 kilowatt of solar power on our rooftop, which caters to roughly about 18 to 20% of our energy needs. And then we are also engaging a company which is called Smart Joules. Their business model is that they come and study your whole system, and then they change the necessary equipment, and then whatever the energy saved, they take 70% to 80% of the saved cost, and then they leave you with 20%, but you don't have to invest anything. They change the chillers, motors, pumps, fans, lights, and all of that. And then they put their own people to control the energy. And then on the savings, we have a share. And this we have implemented in Aravinda Hospital, Madurai. And then there was a reduction of about 27% energy consumption. It's not a small amount. More than the money part, I think the carbon footprint that gets reduced is really, something we really would like to extend to other hospitals. So, and of course, the water that we use, we recycle. And then we have got a DWATS plant. So whatever the water we use for the restrooms and all of that gets recycled for the garden. So these are some of the measures that we have taken at our lab. Thank you.
Well, if I can come back, that's fantastic to hear. And I don't know, perhaps you've already done this, and I apologize if I haven't been made aware of it. Have you written about this, publicized it, published your data? Because that would be a fantastic case example to use, I think, exactly, for the UK.
Yes, and certainly we can look into some of the products that we do. We can certainly try to publish some article.
I'd be very happy to hear of that and support it if you'd like. That would be great, because I think, like I say, that's really something that we need to look towards. And well done.
Thank you. Thank you. We are a low-cost player, so we have to be very, very careful in what we do.
Yeah, and you do things right. Look, I when I finished my training, I lived in Cambodia for 5 months, and I trained the first ear surgeons in the country. And obviously, we reused everything, and it's fantastic. It's the way it should be. So, I understand it's out of necessity, but it's actually the right thing to do. So, yeah, thanks.
Marley, you had a question on Plastic West, or comment on first Plastic West. You want to unmute yourself?
Yeah. Thanks. It was a great talk, Dr. Bhutta, especially since LVP is also making a lot of efforts in this green movement. And like Arvind, actually, we have across the network 650 kilowatts of solar power already installed, and maybe around another 300 being installed in the course of the next couple of months as we speak. But yeah, so my question was related to the point where you said that, okay, we should try and reduce as much as possible, but it's inevitable that we're going to be generating some amount of plastic waste. So what are the efforts that are being made in the management of this in order to reduce the carbon footprint in that area?
Yeah, sure. So the NHS has a plastics pledge in the UK to reduce the amount of plastic, but you know, exactly what that entails, I'm not, is still being worked out, we should say. You're right, we should minimize plastic, but of course it comes from fossil fuels. If you're interested, you can read my opinion piece published a few years ago about plastics in healthcare, where we estimated that between 2 and 3% of all the plastics produced in the world are for healthcare. And we called upon this to be discussed. Having said that, I'm not totally opposed to plastics as a concept, because actually, if you have a plastic product, and plastic is a very good material for some things, as long as it's reused and reused and reused and reused, then it's the right thing. And plastics, if it's disposed of in the right way, again, isn't as bad as you may think. Obviously, plastic pollution is horrendous. That's not to say that we shouldn't, of course, reduce plastic wherever and however we can. And I think that comes down to, again, if you've got plastic packaging, yes, you should minimize it. But actually, if you've got plastic packaging and you're using that packaging only once because the product it contains is used only once, then of course, you're generating huge amounts of waste. Whereas if you've got plastic packaging for a product that is used 1,000 times and then is left on a tray and sterilized in the tray, then automatically we've hugely reduced the amount of plastic that's there. And people have tried other products, you know, biodegradable plastics, as they call them, but they have their own issues as well, because, you know, they release methane as they decompose, and that's a potent greenhouse gas. So I don't have a magic solution to plastics other than to say, I think the whole reduce agenda to wherever, as low as we can get it, is very much part of the solution.
Thank you.
Dr. Raja, you want to go back to your comment on whether there is industry pressure for single use?
Yeah, I just thanks again, Dr. Bhutta, for that very nice talk. I was just thinking if you are aware of any discussions with the industry on single use and what's their response to that, but I'm sure that will affect their bottom line if we go to single use for most of the consumables. So any thoughts on that?
Yeah, so there is work going on in England, I know, on that. So there's something called the Sustainable Healthcare Coalition, which has actually brought together industry players to try and discuss these issues. And I think we need to remain mindful of it being a two-way conversation, where, you know, some of the industry could turn around and say, well, we're supplying you with single-use products because that's what you're asking for. However, I'm not naive to the fact that many of these companies are trying to promote the linear economy. And I've had my own experiences. I was asked to speak, I won't name the name, at a major supplier to the NHS of gowns and drapes as single-use products. They asked me to speak at their sustainability meeting, and I said, sure, I'd be happy to. And then they asked me the topics I'd be speaking on and whether I'd be speaking about single-use versus disposable. And I said, well, yes, I think that's an important part of the strategy. At which point it went to the executive board of that meeting and my invitation was withdrawn. So that's interesting that, you know, exactly that. But I think what it comes down to is we need to have a conversation with them, but we need leadership from within, and we need to break down the marketing nonsense that we're sometimes told around infection control, around that it's economically better to have single use. These things are bounded about, and like I say, through some of the research that I've done and partners I work with have done, we've dispelled that myth. And I've said to many companies, it's fine if you think that your product has lower carbon footprint or lower costs, come to me and show me the data and I'll happily go through it with you. To date, nobody has done so. So we have to fight back and we have to seek the truth and show leadership in this. But yeah, the commercial interests, I'm afraid, will always be something we have to battle against. But perhaps, as I'm hoping, the idea of a servicing model may help to change things so that it's a win-win for everybody.
Thanks, Dr. Buddha. Chirantan, I think it may be good to call in Dr. GC from LVP, who probably would have some wise thoughts on this. Dr. GC, you have any comments?
Yep.
Thanks, Raja. I think it's a very interesting topic, and I'm very happy that somebody is working on this full time. Bhutta, congratulations and thanks for bringing this onto this stage. I think listening to all these talks, I think unless we create evidence that multiple use is not against infection control, you can have good infection control. So generating that evidence, I think, is one thing that is very important. The second thing is, at a policy level, how can you make sure that the companies don't run after quarter-on-quarter growth, but actually are looking at their carbon print and their viability for the planet as a whole? So their responsibility is not just to shareholder, but to the planet as a whole, I think is a part of the policy level that needs to come. Unless that comes, companies will go after quarter-on-quarter shareholder value, and we will not be able to save the planet. I think those two levels of work, I think, is what is most important. Thank you.
Mahmood, can I respond to that a little bit? Especially
Please.
From a business school professor angle. So there is actually a lot of conversations happening around stakeholder responsibility, not just responding to your investors or shareholders, but being careful about how you may be responsible to stakeholders around you. And I think medical firms are slowly waking up to this, Dr. GC. This also has implications for recalibrating the operating models of hospital systems, both in rich and poor contexts. To me, I completely hear you that we need to generate evidence. And that's basically why I thought Dr. Bhutta's talk would be so important here. And we do want to carry on this conversation to generate collaborative work, to do some education modules with IHOPE and LV Prasad, such that we can build more awareness around this. So I think that's my quick couple of cents here. Mahmood, if you want to chime in, most welcome, and then we can wrap up the talk today.
Sure. No, thank you. I completely agree. I think there's learning across different contexts. I think you're absolutely right with the points that we have to create policy and that's why I'm working with people in infection control. I'm working with people who are experts in sterilization. I'm working with experts in biomedical engineering, looking at what causes all of these various aspects of it. So I think it's a complex problem, but we need economics models and we need learning from examples as well. So the stuff that you've already highlighted that you're doing in India is fantastic, and that it should be. I'd be very happy to promote that in any future talks I give. But I think we're in a different place now to where we were, say, 2 years ago, where I still felt very lonely. Now the world is going, oh, this is important. You know, I've been waiting for this moment for many years. It's great to see it's here. It's great to see that there's so many people interested. The problem is it's too many people now, but that's fantastic. And we just need to direct all that goodwill and energy to the right thing. So please, let's continue this conversation.
All right. Thank you so much. So if you are okay, Dr. Raja, let's wrap this up. Much appreciate everyone's comments, and you can look up Mahmood's email, and Mahmood, if you want to put it on the chat window, people can connect with you over emails. And thanks everyone for coming over on a Friday evening.
Thank you, everyone.
So that's the number, that's the email address. All right. I'm going to leave the chat window now. Thanks, Arnaz, for all the logistical help as well. Bye-bye.
Thank you. Thank you. Thank you.
Have a good weekend, everyone.
Thank
Have
you.
a good weekend,
Thank
Dr.
you.
Bhutta.